Good evening, everyone. I am Oindrila Datta from Indian Chess Society. I am the coordinator of the training and education initiatives of ICS. So today we bring to you a webinar with the Southeast Asian Academy of Sleep Medicine. And this webinar is sponsored to you by ResNet. And before we begin the webinar, I would like to mention to everybody that NAPCON 2023 Delhi registrations are live and we don't have a lot of days left. So if you have not registered, please do it right now. So as you know that we are conducting a series of webinars every fortnight, and they are on extremely relevant topics with several eminent panelists. And along with that, we are bringing together a few very good panelists from international faculties, our present national faculties. And today our topic of discussion is on non-invasive ventilation. So before I begin, before I hand it over, I would like to introduce our faculties to you. At first, we have our speaker, Dr. Himanshu Garg. He is the respiratory and sleep physician, Gold Coast Lung and Sleep Clinic, Gold Coast, Australia. And we have another faculty with us who is also the moderator, and he's going to deliver a talk as well. He is Dr. Milind Sovani. He's a consultant respiratory physician, lead clinician ARCU, and complex long-term ventilation, Nottingham University Hospitals, NHS Trust. He's also a visiting professor at University of Derby, UK. For the panel discussion today, we have our panelists, Dr. Supraja. She is the Director and Senior Consultant, Pulmonology and Pulmonary Rehabilitation, Medway Institute of Pulmonology, Medway Hospitals, Chennai. Then we have Dr. Amit Mandal. He is the Director of Pulmonology, Sleep and Critical Care in Fortis Hospital, Mohali. Then we have Dr. Amrita Bhattacharya. She is the Consultant Respiratory Critical Care, CMRI, Kolkata, West Bengal. So these are our panelists, and I am very eager to listen to all of them because they have a lot of information to give to our doctors and our audience. So after I do this, let's just now bring Dr. Milind Sovani, and he can introduce the session and then move on to Dr. Himanshu Garg with the first session. Thank you.
Good evening, everybody. I'm Milind Sovani, one of the respiratory physicians currently based in Nottingham. I would like to thank Indian Chess Society for organizing this webinar on NIV, and I would like to welcome all the speakers and panelists. So we will the flow of today's session is I will open with basics of NIV, followed by Dr. Himanshu, who will be speaking about troubleshooting. We will then have our panelist who will present cases, and we will jump in as well. We'll have some question answers, and the idea is to try and cover important aspects of NIV so that we can all learn and hopefully improve care for our patients. So I'll start with my presentation, and then we'll follow with Himanshu's presentation. I'm going to share screen. And, okay, is it in full screen mode now?
No, sir. It's blank.
Is it? Okay, let me try again then. Stop sharing. Share screen. Can you see anything?
No, sir. It's a black. Nothing's visible.
Okay. Now?
Yeah, it's visible, but not in the slideshow.
Okay.
It's gone. It's gone. It's gone.
Let me try once again. Can you see something now?
No, sir.
And can you see the presentation, please?
No.
No? Hmm. Okay. 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 Um, and if I share screen now, how about that?
Yeah.
Thank you. Thank you. Sorry for the delay. So today we'll talk about NIV in respiratory failure basics, and we'll briefly touch on few updates as well. So I'm, as I mentioned, I'm Milind Soni based in Nottingham, and my special area of interest and expertise is respiratory failure and all things related. So today we'll briefly talk about basics of acute respiratory failure causes, basics of NIV, and some take-home messages. So we all know that respiratory failure is type 1 and type 2. I'm not going to go into detail here. You know far more about this than I do. So type 1 is just VQ mismatch really due to all sorts of reasons, whereas type 2 is predominantly because of reduced alveolar ventilation. Whenever there is reduced alveolar ventilation, there is reduced CO2 clearance and hypercapnia ensues. It can be due to drive or muscle fatigue or increased dead space. And particularly in COPD or indeed OHS, you can have all three issues there. So if we look at the schematic approach, so we have got the electrics, which is the pacemaker wire. So we have got the respiratory center in our brainstem. We have got the muscle pump, which moves the diaphragm and moves air in and out, and the membrane. The key thing I wanted to highlight is deep, slow breathing is much more efficient than rapid, shallow breathing. And the whole point of NIV or any respiratory support is to move from an unstable state of rapid, shallow breathing to a stable state of more deeper and slower breathing. Now, just to highlight this, if we have got two patients, both with minute ventilation of 6 liters, if one has got tidal volume of 600 mL and respiratory rate of 10, and if we say that the dead space is 150 mL, then in the first case, alveolar ventilation is 4.5 liters. And in the second case, minute ventilation 6 liters, but respiratory rate of 30 and tidal volume of 200. Now, out of this 200, 150 mL is dead space. So it's only 50 mL of alveolar ventilation. So you've got alveolar ventilation only of 1.5 liters. So you can see how a rapid shallow breathing is not stable. The other thing I wanted to highlight is when we look at the alveolar gas equation, which I'm sure you all know, which is PaO2 equals PiO2 minus PaCO2 by respiratory quotient. So if we use that, and basically if you have got some of arterial CO2 and PO2 either more than 125 millimeters or 16.5 kPa whilst breathing room air, what that would suggest is that patient's lungs are okay and the hypercapnia is more due to drive issue or muscle issue. So respiratory failure, it's an imbalance between load and drive. You can have resistive or elastic load. Respiratory muscle issues can cause pump failure, and transmission issues can cause, again, significantly reduced ability to handle load. What sort of loads we are talking about? So the main loads we need to remember are resistive loads. So bronchospasm, particularly important in COPD, and airway obstruction, which is seen in OSA and OHS. We can also see elastic load, intrinsic PEEP, because of again in patients with COPD. You can have chest wall elastic load, and sometimes with things like sepsis, you can have minute ventilation load. When we come to a strength issue, you can have either drive issue or impaired neuromuscular transmission, such as phrenic nerve injury or cord lesion or Guillain-Barré, and muscle weakness due to a number of factors, including things like motor neuron disease and myopathies and hypokalemia. So I think these are important things to remember when we come to try and treat a patient, because depending on which of these factors are involved will decide what sort of settings we provide. Before we launch into NIV, just wanted to highlight a trial from Australia. Basically, what they did was looked at controlled oxygen versus uncontrolled oxygen in patients who came to ambulance over a long distance. And those patients who were given controlled oxygen, particularly those with COPD, tended to have much better outcome. So we know that uncontrolled oxygen treatment can lead to reduced drive in patients with COPD and poor outcome. So even before we start an IV, it is really important that we give controlled oxygen. Looking at NIV, we all know that NIV in a big way started with negative pressure ventilation, particularly around the polio epidemic. It started in Boston in 1928, and during polio epidemic, it was used on a very large scale. Subsequently, positive pressure ventilation using mechanical ventilation and endotracheal intubation was used. And then in 1980s, Meduri et al. Started using NIV for COPD, and then it has gone from there. So today what are we going to do is we'll look at goals of non-invasive ventilation. What are the goals? Which are relieving symptoms, reducing work of breathing, stabilizing gas exchange, and ultimately avoid intubation and mortality. Before we go into NIV, just a quick one about setting up NIV. In most ICU ventilators, we have got endotracheal tube, we have got an inspiratory limb and an expiratory limb. But in most NIV setups, non-invasive positive pressure ventilation, we just have a single limb and an exhalation port. So it's really, really important that we do not block the exhalation ports. It's important to know what is the minimal amount of fluid that's essential during exhalation, so that CO2 is washed out, so patients don't rebreathe their carbon dioxide. And then how do we set up? So we just mentioned there is an exhalation port. Make sure that it's not blocked. Choose the right mask. Start with lowish EPAP and a tolerable IPAP, and then gradually increase it. The key thing is you have to watch the patient, see their chest movements, see that they are synchronizing, see the chest is rising and falling, and you can often see improvement in PO2, improvement in respiratory rate, improvement in saturations. During COVID pandemic, we all know that we also had a slightly different way of configuring the circuit, but hopefully we wouldn't need to do that for a long time. Just briefly talking about mask. Using the correct mask is single most important thing in any NIV delivery system. So we have got the standard face mask. It's the most commonly used mask and will often be used in acute setting. Problems with it are claustrophobia. Nasal pillows sometimes can be used in acute settings, but not often. The total face mask on the top right corner. So we use it often. What it does do is reduces the risk of pressure damage, and it also improves patient tolerance. However, you can see that the dead space within the full face mask is much bigger than what's in the face mask. So you do need a decent ventilator with a powerful motor and decent sensors, so that it can sense and drive enough air through. Otherwise, there will be significant asynchrony. We then look at the oronasal mask. We quite like this. it has got really small dead space, and particularly somebody who is claustrophobic or somebody who is too weak, for example, neuromuscular patients who just cannot synchronize, using oronasal mask really makes a big difference. Nasal cannulae, nasal masks rather, or nasal pillows. It's not often we would use it. Sometimes we would use it, and it is somebody who is coming in acutely but already is at home with nasal pillows. So they are comfortable using that interface and not opening their mouth. Otherwise, you'll have a large leak through the mouth. So it's very rarely that we would use nasal pillows. Nasal pillows. And then the helmet or hood can be useful in ICU setting. It's important to remember that it has got a very large dead space. So you need fresh gas flow of up to 100 liters per minute or more, and you need to make sure that you have got the ability to deliver that. Otherwise, this can cause CO2 rebreathing. It does improve. It does improve tolerance. It does reduce the risk of pressure sore, and there are some suggestions that this may actually reduce the risk of an IV failure. But again, you actually need to do it in right setting with the right gas flow so that it doesn't lead to CO2 rebreathing. Now, coming to modes of ventilation, we all know what modes are. I'll briefly touch on it. So it can be either controlled, which is either pressure controlled or volume controlled. Most of the ventilation we do these days is pressure controlled. And then it's time cycling. What does time cycling mean? Time cycling means you set the inspiratory time. And you set the respiratory rate. So after, for example, 1.2 or 1.3 second, at the end of that, machine knows that it is end of in inspiration. It drops the pressure to the bottom pressure or EPAP, and then you go into exhalation mode. Control modes are often used either when patients are very drowsy and comatose, or patients who have got OHS or neuromuscular conditions. Support mode means whatever pressures you set up, patient initiates the breath and machine will provide that support. So it's flow cycling and pressure support. So flow cycling means when patients peak inspiratory flow, when the machine delivered flow falls below a certain level of patient's peak inspiratory flow, machine then cycles into exhalation mode. And then there are a combination of modes, but today probably we are not going to go into more detail. Maybe another day. So spontaneous or supported breath, we know that we have got the bottom pressure and we have got the top pressure. What does the bottom pressure or EPAP do? It opens up the upper airway, it improves FRC, and more importantly, during an IV, by ensuring fresh gas flow during exhalation, it ensures that CO2 is washed out. So it's really important that you know what is the minimum EPAP for your machine to ensure that patients do not rebreathe CO2. IPAP, as you know, that's the top pressure, and that's what's the driving pressure, or the driving pressure is IPAP minus EPAP, but it's the IPAP you set which determines how much alveolar ventilation, how much tidal volume and alveolar ventilation patient will receive. Higher the IPAP, higher the tidal volume, but also if you set IPAP too high, then that can lead to intolerance of worsening leaks. So we have just gone through mechanisms of NIV related improvement. So EPAP, it offsets intrinsic peak, particularly in COPD patients. The key thing is not to overdo with CPAP or EPAP in COPD. It improves FRC and oxygenation and ensures CO2 washout. And we have looked at the role of IPAP as well. So pressure support ventilation, this is a trace of pressure support ventilation. So here with the red arrow, you can see a small notch. That's when patient has initiated breath. Patient then breathes up to IPAP, and then at the end of inspiration, it comes down. Now this is controlled ventilation, and you can see compared to where in pressure support mode, each breath is of variable distance and variable volume. When we go to controlled ventilation, it's absolutely mechanical. So there is no patient effort there. Machine gives the breath in, continues to give breath for a certain amount of time, and then drops the pressure to EPAP, whatever pressure you are set to. So all breaths look very similar, or same really. That's because it's machine driven. And as mentioned earlier, we would use these modes particularly in very comatose or sedated patient, or OHS, or particularly neuromuscular, where patients are too weak to trigger their breaths. It's important to make sure that we get the settings right. If our pressure support or IPAP is too low, then patient can become tachypneic or tired. If it's too high, then as mentioned earlier, it can lead to mask leak or poor tolerance. And flow or time cycling again. If it's a long cycle, then it can lead to gas trapping, or if it's too short a cycle, then it can lead to ineffective breath. So as we know, COPD was the first group where NIV was trialed in large numbers. Medri and colleagues had initially reported success, and then a number of other researchers and clinicians tried it out. One of the landmark study was called study called UNIV. This was by Mark Elliott's group in Leeds, UK. And basically what this study showed is that on medical wards, they recruited about 236 patients, and what non-invasive ventilation did in patients with hypercapnic failure in COPD, acute hypercapnic failure, is that it reduced rate of intubation and reduced mortality. And you can see pH had a direct impact. So lower the pH, better, worse the outcome, and higher the pH, better the outcome. Subsequently, Conti et al. Did actually a randomized controlled trial between NIV and invasive mechanical ventilation and demonstrated improved outcome with non-invasive ventilation. The reason for that is with mechanical ventilation, there is significant risk of hospital-acquired pneumonia or ventilator-associated pneumonia, line-related sepsis, and other infections which cause significant morbidity and mortality. Meta-analysis again demonstrating benefit of NIV in acute excessive COPD, and it has shown reduction in intubation, reduction in mortality, greater improvement in pH, CO2, and significant reduction with number of other other complications. This is a nice slide again from Mark Elliott. Basically, what it shows is that between pH of 7.35 and 7.3, the risk of NIV failure is risk of standard treatment failure is low, whereas once pH is less than 7.2, then about 50% patients will fail NIV. So certainly, once we go below pH of 7.25, we need to have a plan in place as to what are we going to do if NIV fails. And this is specifically for COPD, yeah? Again, what about those patients who are comatose? Well, actually, it's associated, if anything, with similar, if not better outcome, because their tolerance is much better. But this is only valid if that coma is CO2 narcosis. If that is because of, for example, stroke or something, that's a completely separate thing, and one needs to be aware and make sure that we are not treating stroke with non-invasive ventilation. Anybody who is comatose with stroke, and a bit of hypercapnia, NIV is not the option. As this study from Chandra et al. Shows, we are doing more and more NIV, and we are doing it for sicker and sicker patients. And the success of NIV has improved over the years, but also when NIV fails and is converted to mechanical ventilation, the mortality has gone up. The reason for that is because we are taking patients who are sicker and sicker and offering them NIV. So when that fails, I think it is better to have a plan for those patients right at the beginning as to whether NIV is ceiling of care, or whether and whether mechanical ventilation has any realistic prospect of success. Obesity, on the other hand, when we do treat acute hypercapnic respiratory failure with NIV and then provide NIV support on a longer term basis, then it is associated with significant improvement and significantly improved survival. I just wanted to share some trends. So I think what I'm showing you here are data about pneumonia and reduction in mortality, significant mortality over a number of years in pneumonia. But what we have seen is that mortality because of NIV continues to remain high. I would like to point out here that our unit's mortality is 13%, which is really, really good. And what we can see is that mortality from obesity has come down, but mortality from chest wall, neuromuscular problems, other conditions, and maybe even COPD hasn't really gone down to the extent that we would have liked to. Now, what are the common conditions for VUs NIV? So COPD remains one of the commonest, followed by cardiogenic pulmonary edema, obesity, hypoventilation, and then neuromuscular and chest wall and a number of other conditions. We were one of the centers which has looked at outcome from NIV and something which we have published. So NIVO score, so consolidation, low GCS, AF, acidemia, late acidemia, and poor performance status are all associated independently with poor outcome. Now, what are systematic factors that affect NIV delivery and NIV outcome? Late initiation of NIV is one of the most important predictors of NIV failure. And NIV started in a general ward rather than in a specialist unit. Those are the two important systemic issues that we need to address if we want to ensure that NIV is successful. Quality of NIV again is important. We need to ensure that we optimize the pressure. We need to document the pressure and the titration reason. And we need to optimize NIV settings as well, because a large number of patients, when we looked, there was significant room for improvement. MUSC is another factor. Claustrophobia, delay in initiation, but inappropriate initiation, pressure sores, dry mouth, asynchrony are all important reasons associated with MUSC. And it's important, it's crucial really that we address these issues, because if we don't address, then there is increased risk of intubation and hospital mortality. So what are predictors of success? Prompt initiation of an IV within 1 hour. Door to mask time needs to be less than 1 hour. You have to look at really choosing the right mask, using correct fitting, using correct respirator, ensure that respiratory rate is going down, that pH is improving. Mask tolerance or intolerance is seen in about 5% of patients, and you have to look at other options such as hood or high flow nasal cannula. Delirium is 3 times more likely associated with an IV failure, so treating that becomes important. Then your systemic factors such as where you start, how quickly you start an IV, your staffing ratio, staff training, your learning from failures and mistakes, all these things are important to ensure that you as a unit, because we have to remember NIV it's a team game, because you and I, we just say somebody needs an IV, it's our nurses who actually deliver it. So the whole team needs to be fully bought in, trained, and be passionate about NIV. So this is BTS ICS guidelines in terms of when do we start an IV for which particular group, and what I wanted to highlight. So we had written these guidelines. I'm part of the guideline group in 2016. So for COPD, pH it has to be less than 7.35 and CO2 more than 6.5. But for neuromuscular, acidosis is not important. For obesity, acidosis is not important. If patients are hypercapnic with OHS or with neuromuscular problems, they need NIV. Whereas in COPD, for acute NIV, respiratory acidemia with normal bicarb and high CO2 is essential. And then worth looking at, I'll be happy to share this as well. I'm not going to read this through, but there are indications, there are guidance in terms of what sort of settings to be used in what condition. And red flags are pH less than 7.5, respiratory rate increasing and not improving, And in that case, we need to have a plan in terms of whether for mechanical ventilation or not. So from my point of view, I would say take-home messages are mask fit is really important. Door to mask time, again, very important, should be less than an hour. You need to, of course, treat other things such as, steroids, nebulizers, antibiotics. I'm not going into that. We have to have optimal settings. For COPD, I would use ST mode with rapid rise time. For obesity, I would use higher EPAP, and I would use pressure control mode for MND and OHS patients. Make sure that your trigger sensitivity adjusted, and most importantly, really spend time with your patient to assess how they are responding to whatever settings you've got. Stand there next to them and adjust the setting so that you can actually achieve success and your patient can get better. Just a brief one, we have looked at also continuous monitoring using transcutaneous arterial CO2, transcutaneous CO2 compared to arterial, and that's going to be a new modality which is going to come up over the next few years, where we will have continuous trend of CO2 monitoring by transcutaneous probes, and that again will add a big improvement in terms of monitoring. Thank you. Yeah. Yes. Thank you again. I hope it was not too fast. I'll be happy to take questions at the end, but what we are going to do first is we will start with Dr. Himanshu's video. He's going to tell us about how to troubleshoot for NIV. We will then have time for discussion, where we can discuss cases as well as any other questions you have.
Hello, good evening, everyone. Thanks for joining for this important webinar. And thanks, Indian Chess Society, for hosting this important topic. And thanks, Milind. Thanks, Shivani, for inviting me to participate in this. Unfortunately, I can't be here live, and I hope you will be able to get some information from this recorded session. So I am Dr. Himanshu Garg. I think most of you will know me. I've been practicing in India till late, and I'm currently based at the Gold Coast. So the topic, I hope Milind will go over in the basics of NIV, and I'll more sort of talk about troubleshooting of the non-invasive ventilation. I think when it comes to troubleshooting, one must look at whether we've got the patient indication right, if the patient is right, have we got the right staff and the management plan in place, are we using the right device, and also then look at the technical settings and understand the waveforms. So I'll briefly go over these things which I think are important in understanding the troubleshooting of the non-invasive ventilation. So the most important bit is to match the right patient and therefore look at the indications. The most common indications would be COPD, obviously. In hypoxemic respiratory failure and asthma, I think it should only be used when you have a backup plan, either in an ICU, and it's not typically an indication. I think type 1 respiratory failure, where you can often, it is a bridge to ventilation. Sometimes you can avoid that, but I don't recommend that being used when you don't have an ICU backup. So cardiogenic pulmonary edema, postoperative settings, post-extubation, and of course, do not intubate status. When you have, you don't have the liberty of taking someone to the ICU, and you can do that on the ward. Now, the patient is breathless, high respiratory rate, use of accessory muscles and paradoxical breathing, and of course, low pH and high PCO2. So what are the indicators of success? Includes a younger age. Not necessarily always true, but yes, if we were to truly look at the success indicators, that does make a difference. Low acuity of illness, ability to cooperate, and better neurological score. It's something that I think one has to be really careful in trying to attempt in someone who's dizzy, not really oriented. I think they are hard people. You have to really monitor them hard. less air leak, moderate hypercarbia, moderate acidemia, and improvements in gas flow within the first 2 hours. I think this just tells us the importance that we will need to monitor them very closely. These are patients who are sick but not very sick, who are not the ones who are requiring immediate intubation. So you have some leeway in monitoring these patients before you think about deciding. So that, I think, is the right indicator, and one must be aware of the indicators of success. And as you use that more often, I think you get a better idea of who's your patient who's going to respond well. Very important, I think, and often there are constraints, I know, but it's a service that should be run by a clinician with trained and experienced staff designed to support 24/7. It's not something that we can start and then we have no night cover and then we can forget about it. So in this decision of where the NIV therapy should be initiated or should be hosted, I think is an important one. There has to be the 24/7 cover with the trained manpower. You can train a cohort of staff with appropriate competencies and then keep making sure that we know, especially in India, that there is a lot of transition of staff and turnover. So you have to make sure that the competencies are passed over. All the new staff will need some training, regular continuing program for the new staff involving minimum competency assessments. I think these are things that we do for all other procedures like bronchoscopy, like any other procedure, but this has to be thought through, and this is not something that will come automatically to a lot of staff. So, and every time I think an NIV plan is initiated, there should be a plan in place, which may mean that yes, in case this patient does not improve in two hours, or the parameters do not improve, or the drowsiness worsens, or the disease state worsens, they may need to be taken to the ICU, or maybe in the ICU already they need to be intubated. So there has to be an escalation plan and a decision that at what stage would you consider them for ventilation. And I think yes, we want to prevent as many intubations and ventilations as possible, but we should also be not at the cost of pushing it too late when you can't really salvage a patient. So we don't want to push it too late either. So it's a sort of delicate balance that one has to achieve in this setting. And I think NIV over these years, as we've become confident about it, the staff has become confident, and there are remarkable situations. There are situations where the patients had really crashed and we were thinking we'll not get away without intubating these patients, but very often we find that we are able to help these patients in an acute setting. So I think wherever possible, it's still important to have a consent from the patient. Not a usual practice, as these patients are sick and you think of it as just another thing that you do in an acute setting where you don't have to worry about taking consent for everything. But I think it's an important thing, especially the circumstances, that the medical legal hassles. It's good to have, I think, introduce this practice of just getting explaining to the patient to the extent possible, or to the family, what are you trying to do. And when I think you could just have a checklist which has that ensures you have taken the arterial blood gas, the patient meets the indication, and there is an appropriateness of the escalation of treatment. So I'm emphasizing this again. I think I don't think that the NIV should ever be initiated without a backup plan, without everything on the standby, and you never know when you have to go back and intubate these patients. You might just start with a lower IPAP so as to improve compliance. Think of a patient who's not breathing and who's struggling to breathe, and trying to put something on the face is often very frightening. So I think we have to be patient in this setting. And I think people who have initiated will tell you this can be really harsh for the patients, and they will resist it in the beginning unless you take it a bit gently maybe increase the IPAP, say about 2 centimeters every 10 minutes, and then maybe target an IPAP of 14 to 18 centimeters, depending on the situation. This is just a rough guide. And the EPAP could be started at a 6 centimeters and then slowly increased where needed. Oxygen may be required to be maintained in the system. So most of these masks have a port where you can entrain the oxygen is low, because remember, the NIV will help, but the major function may be to wash out the carbon dioxide in this setting. So when you think you're not doing well with the NIV failure, look at the treatment options, the therapy. It's just not, if for example a patient has come with a COPD, I think, have they been optimized, nebulized? Have you given them systemic corticosteroids? Important to look at all those things. Also consider that if they have any complications like a pneumothorax. We are using positive pressure here, so there is a risk of pneumothorax in these patients, of aspiration, pneumonia, and they could also be excessive leak somewhere in the system, or we're using too much oxygen. These are common things, I think, which can lead to failure. If we are aware of these, I think we can make sure that that's not happening. This is the major challenge, the mask intolerance. This is ensured that the mask fit is optimal, because these patients are often struggling to breathe and they will feel a bit claustrophobic when the first time you put on a mask. So I think this is an art which an experience can teach you. If you've dealt with some of these patients, it may be a bit sort of intimidating in the beginning, but as you go along and you work with these patients, you become confident yourself, and then you're able to take these patients on this journey. And adaptation is important. You have to hold the mask, or even give the mask to the patient, then they can hold it for some time, get more used to it, and then you gradually tighten the mask. So we do get a situation in the ERs where you have to literally hold patient's hand and have to really force it on them, but that's never desirable. I think it can increase the anxiety of the patient, but in a very delicate situation, in a situation where there is no other possibility, I think those things are still practiced. So just a 2-finger test, very commonly used. That's the appropriate tightness. How tight should the mask be? I think you don't have to make it too tight as well, but you can't have it too loose just to avoid any leaks. But this 2-finger test, so that the mask is held right. So how do we judge if somebody is responding well? You add when you monitor if the parameters are not improving, but the PSO2 improving, but we have to not increase the saturation. If the PSO2 or the carbon dioxide levels remain elevated, just make sure you're not using a lot of oxygen. Is there any asynchrony, synchrony between the patient? Check the circuit leaks. Adjust the TI max, which is the inspiratory time. I think Milind will go over that, and I'll also briefly touch that. Increase the EPAP. Make sure that there is no rebreathing happening. Remember, the masks that we use for NIV have a expiratory port, so the CPAP mask will not have that. So it's important, and I've seen this happen a few times, where you're trying to use the CPAP mask for the NIV, which can be sometimes dangerous, because you have to have an expiratory port in these masks, or the mask that we use with the ventilator, which will have both the limbs, an expiratory and an inspiratory limb. So if you're trying to use the same mask on the NIV, it can be dangerous. Make sure there are expiratory ports. These masks, modes of ventilation. If the PCO2 improves, but the PCO2 increase the FiO2, or then you have to add the FiO2 or increase the EPAP. If the tidal volume is low, then you have to increase the IPAP. The other thing is to look at the nasal congestion and dryness, often a big problem, considering the nasal resistance, because if the nose is blocked, then you have to use a full face mask, and also you can use a nasal corticosteroid to ensure that they can breathe well through the nose. Depending on the local environment, the pressure at which the ventilator at the setting can be adjusted. The tubes can really, especially in the winters, can get condensation. Some of the new machines have got smarter with the condensation. They're able to have detect that and address that. Otherwise, you can have it under the beddings and cover the tube with something warm so that there's condensation that can cause a bit of problem. Nasal inhalers for addressing the nasal congestions. Maybe also used by nasal corticosteroids, very commonly done for these patients, especially when you're doing it on more chronic settings. It's common to see patients who've had NIV for some time to have impressions or sometimes even abrasions of the skin with the because the mask has been held tightly. So you can use some of the home remedies. I think home rubbers, use some artificial skin, or maybe use a nasal pillow to make sure that don't get it. I think once this doesn't happen as much in the chronic setting, but as you use it more chronically, you have to make sure that these patients don't suffer these consequences. The gastric distension can also become a problem after a few hours. This generally is tolerated because the pressure is really don't go up to more than 5. Reduction size at times can help. Very rarely would you have to put in an NG tube to cause distension, but remember, if you have to do it, it will cause you some leak as well. Some amount of leak is inevitable. It's universal. Despite pressure-limited ventilators are able to compensate for it because the sustaining airflow also contributes to it, but they contribute to arousals and desaturations. And yes, you have to be aware of it. If you are using an oral nasal mask, it should generally be fine. But if you're using only a nasal mask, that can become a problem. And you can use a chin strap, depending. That can also decrease the leakage from the mouth in that setting. An oral nasal mask may be tried, but with an anti-asphyxia valve, mouthpiece will eliminate the problems through the nose and may occur. As I said, if you're still having failure in the gas exchange, then look at the minute ventilation, increase the IPAP, look at the air leaks, adjust the trigger. I'll just show you some of these waveforms to make sure there's no rebreathing happening. And use of EPAP should be greater than 4. That may lead to the rebreathing to happen if it is too low. So these are generally the waveforms you will see in the NIV. There is the top one, the blue one is the pressure, the second is the volume, and the flow. So these are the 3 waveforms I think you would see on any NIV settings. Depending on what machine you're using, they may appear a bit differently, but most of them are similar. So this is the difference between a volume mode, where the volume is fixed and the pressure is variable, versus a pressure mode, where you see a fixed pressure and then the volume can vary breath to breath. That's then a fixed volume mode. This is what I think is most commonly used, the pressure cycled NIV ventilation. This is the pressure control. When you see that it is the 2 breaths are controlled and they're similar, all the breaths, and this is dependent in the second setting, which is the pressure support ventilation, because the patient is triggering it. It can be variable. Both the timing of both the breaths can be variable depending on the patient inspiratory time. So that's the difference between PCV, which is the pressure control ventilation, and the pressure support ventilation. In the support mode, it is the patient who's triggering the breath, and therefore it is not at a fixed respiratory rate. In the pressure curve, it's important to understand this is the EPAP, or the end expiratory pressure, and the IPAP, which is the inspiratory positive airway pressure. So the pressure support is the difference between the IPAP and the EPAP. This is the trigger, inspiratory trigger, when the patient takes a deep breath in, and that can be set at different levels. So this is the trigger, and this is where the breath is triggered by the patient in the pressure support mode, and then this is delivered at a particular pressure at an inspiratory and an expiratory pressure. So these are terms I think one has to be aware of. IPAP, which is the inspiratory pressure, the expiratory pressure, the trigger, the PEEP, which is the EPAP, the end expiratory pressure is the PEEP, the pressure support, and the inspiratory time. In the flow curve, the important parameters to understand is the inspiratory trigger and the expiratory trigger. At some point, the cycling will move from an inspiratory to an expiratory mode, which is set at either through an inspiratory or time, or the decrease in inspiratory peak flow to a certain level that can then make the NIV go into an expiratory trigger. The TI is the inspiratory time, the TE is the expiratory time, and T total is the total inspiratory and the expiratory time. This is the volume curve. The TI is the inspiratory time, TE is the inspiratory volume, and the VTE is the expiratory volume. These two graphs where you have the inspiratory and the expiratory volume exactly similar because there's no leak in the system. But if you look at this second curve, there is a difference between the inspiratory and the expiratory volume because there's this. So just looking at this waveform, we can make sure we can identify that there is some leak that is happening that is causing this difference to happen. The VTI is more than the VTE in this, so it's indicative of the leak in the system. So this is the auto triggering. So the breath one is, we can see there is this negative breath or a negative inspiratory cycle which is triggering. So this is a breath which is triggered by the patient. There is no trigger here, and the breath is therefore being auto triggered. Remember, these machines, we set up a backup time with the NIV. If the patient does not trigger the breath within a certain time period, the machine will automatically deliver that breath, and that's a backup rate. So this is an indicative of how the auto triggering is happening in this patient at a level 2. So this can sometimes lead to double triggering. We can see that this patient, before the whole breathing cycle is complete, because we have not said either the patient is coughing or there's something that is happening that is triggering this to happen within the same cycle. So double triggering defines as 2 consecutive ventilator cycles separated by an expiratory time less than half. It can happen when there is the patient is either making lots of efforts or coughing or having rapid shallow breathing. Sometimes that can also lead to that, or the ventilator settings in the inspiratory time or the cycling criteria has been set wrongly, that can cause this to happen. Ineffective triggering, you see that the patients are having lots of these negative inspiratory flows which are not leading to a proper breath. So this is ineffective triggering. A wasted effort is defined by an inspiratory pressure drop simultaneously to the flow increase not followed by ventilatory cycle can occur in patients with system mechanics, inadequate settings, or expiratory inspiratory support. So as I said, you can just, looking at these waveforms, make out some important conclusions like no leak waveform and a leak waveform just by looking at the volume curve. We can make out that what's going on in this patient, and there's a lot of asynchrony. I think Milind will go in detail of the asynchrony. So I think it's important that we make we will face some trouble with the NIV. It is not never a straightforward therapy. It is important to make then proper guide or that is present readily with any of these in the wards, and anyone can use it. So, for example, if you have a persistently elevated carbon dioxide, is there excessive leak? Check the circuit. Is there any rebreathing happening? Has the patient sufficient time on the ventilator? Is the patient very obese? Consider decrease the EPAP if it is set too high. So this is just, I think, having these laminated in the lab or wherever the NIV is used, so that it is at hand for anyone and everyone to use. The mask leaks, small leaks are acceptable. Be prepared to try different masks in a headgear. Consider a foam for comfort. If there is asynchrony between the patient and the ventilator, this is rare in new machines, check the correct tubing. If the patient is making feeble inspiratory efforts, the machine is not sensing, make sure that the trigger sensitivity is right, and may increase the EPAP a little bit. If the patient is very tachypnic, increase the IPAP, and that may help and ensure that the IPAP rise time is as quick as possible. As I think some examples will be shown a bit later. If there is hypocapnia or alkalosis, minute ventilation may be too high, reduce the IPAP. Is the ventilation still required? Just assess that situation. If there is difficulty inflating the chest, is the bronchospasm, any plugging, pneumothorax, a chest X-ray is needed. Any nasal problems should be addressed. Padding may be used, or rhinitis or nasal symptoms need to be addressed. Dry mouth, patients who have to be on an IV for a bit long, can you add a humidifier in this setting? In short, I think dryness becomes an issue, and it is something that you should anticipate and address. The gastric distension can become a problem. You have to reduce the IPAP. Use the nasogastric tube if nothing else is working. If there's persistent hypoxemia, check the oxygen is entrained into the system, or is the patient just deteriorating? Is the patient positioned right? If the patient is aggressive, non-cooperative, sedation can be used, but again, this has to be really well monitored. These patients can deteriorate very quickly, and you have to have a standby intubation if that's going to be the case. So I think I just briefly touched upon some of these issues. The patient NIV is a 24/7 business. It needs to be taken up seriously. There has to be a plan in place. The right patient has to be matched to the right therapy, and occasionally the patients may have problems. You have to have a guide which is readily available for everyone to see in your unit, and your unit has to be well trained. It may appear a bit intimidating, but I think as you use it more often, all your staff get more accustomed to it. But you have to make sure that every time new staff joins in, they get the training and the confidence to be able to do it. It can be done with major adjustments. Sometimes you will not succeed with an
Thanks, Himanshu, for a really informative talk, and thank you again to CSM and Indian Chess Society and Shivani from Dr. Swami from CSM for organizing this session. I think what we'll do now is we will move to Dr. Mandal to hear his thoughts and his take for 2 to 3 minutes. We will then do some case discussions. I think Dr. Amrita and Dr. Supraja has got some cases. And then during this case discussions, please feel free to put in any questions that you have either pertaining to the cases or any of the talks, and we will try and address those as well and as quickly as we can. Over to you, Dr. Mandal.
Thank you, Dr. Milan. I think those talks were pretty informative and self-explanatory, at least in the initial go. I think a lot of the problems that we face is what I think in the last couple of slides, which Dr. Himanshu did highlight, is keeping our nurses and the people who are going to be at the bedside, keeping them as they keep changing. And that's where we probably fall back upon, and that's where we probably make the basic errors. One of the important things in the Indian scenario is that we have the vented and the non-vented masks, and that's where a majority of our problems do happen. And inevitably, an untrained person makes that big mistake of putting in a non-vented mask in a dedicated NIV, and that's where things go wrong. I think beautifully highlighted. The other aspect, I think that's something that we are not doing is, I think, which you did allude into your last slides, Dr. Milan, is the follow-up monitoring that we probably will get into in the next couple of years' time. And I think that's where I think we'll probably be, as of now, we kind of apply the device and kind of forget subsequently what is happening, excepting the blood gas monitoring. We rarely are monitoring the flows. We are rarely monitoring the pressure waves, what's happening. As we were reading up, upper airway obstruction in COPD, which is one of the most common reasons for repeated exacerbations, is something probably we are not addressing during our patient's hospital stay. So I think lots to learn. Thank you for those two wonderful talk, and thank you for the invite. Over back to you, Dr. Milan.
Thank you, Dr. Mandal. I think it's really important point, and whether each unit can say that this is the mask and the circuit that we will use. This is what we have done, is that now there is only one type of mask and only one type of circuit on the unit for acute NIV. What that means is that error is taken care of because
Correct.
It is safe. There will be no CO2 rebreathing. So that is something to think of. And I think what we'll do is, as you mentioned, looking at the ventilator waveforms and things, I've got a couple of examples, but what we'll do is we will get Dr. Amruta to maybe present a case or so, and during that we will potentially get a chance, if we do get, I'll show a couple of examples of how those waveforms are really helpful in understanding what's going on and treating. Just one point with COPD, I think, although we do need a little bit of EPAP, unless there is that's overlap of COPD and OSA, too much of EPAP in acute COPD exacerbation can worsen things as well. So getting that optimal to make sure we don't give EPAP too much, otherwise it causes intrinsic PEEP or auto PEEP, and then that worsens everything. But over to Dr. Amrita to share her case, and then what we'll do is we'll try and discuss that, and then any weightages that come out of those. Over to you, Dr. Amrita.
Doctor, you'll have to unmute yourself, Dr. Amrita.
I'm sorry. So good evening, everyone, and thank you, Dr. Milan. And I'd like to highlight the utility of COPD. Perhaps right now, worldwide, the most acute utility would be in case of a COPD exacerbation. So some relevant points, especially for the youngsters, that some relevant points that plague us at the bedside. Yeah. Is the screen visible?
Yeah.
Yes.
So we have here a small case witness. We have Mr. B. He's a 74-year-old gentleman, and the classical history of severe COPD, history of recurrent hospital admissions, exacerbations, and this time again he's admitted to the ICU with a saturation of around 88% on room air, respiratory rates around 28 per minute, and there are clear signs of increased work of breathing, accessory muscle use, and this is what the ABG tells us. So the first question is whether or not we start NIV, and if we do so, then at what settings? So I think the previous speakers have covered in great detail that this pH, this carbon dioxide, this ABG falls bang in the middle of that perfect sweet spot for NIV application. So a pH of more than 7.35, as the speakers before me so elegantly showed, a lot of patients need to be treated for that single benefit. A pH of less than 7.25, once again, the chances of NIV failure increase. But this pH, this is without question, you see this ABG, you find your diagnosis, and you put on the NIV. Settings. So settings, we kind of start from a basic setting of around an EPAP of around 4 or 5, an IPAP of around 10 to 12. If you're using an NIV, it's always PS over PEEP. So that's something that needs to be remembered. That's a distinction from the conventional ward BiPAPs and the NIVs, that the pressures in an NIV is always PS, that is pressure support, over PEEP. In BiPAP, it's the total inspiratory pressure. So that's one important distinction. The second question that we all face at the bedside, how do we monitor these patients? So I have diagnosed these patients. We have asked the nurse to snap on the NIV. What next? So monitoring, as a lot of my previous speakers have said, that it's not only about the ABG, but it's also about clinically looking at the patient, whether the patient's sensorium is improving or whether he's getting drowsier, whether there's accessory muscle usage, proper chest rise, and definitely carbon dioxide, PaCO2 levels 1 hour after commencement of NIV to see whether there's improvement. We need to remember at this point, so there's been around an hour after we have put the patient on NIV. So if case we observe that there's no improvement in acidosis, no improvement in the carbon dioxide, that's the point where we need to be very, very careful that this is where this patient may be failing the NIV trial. The same patient, 1 hour post-ABG, we've seen in 1 hour itself, there's been a lot of washout. The pH is now around 7.39, PaCO2 is around 48. So the question now, however, is that the patient has woken up. He was slightly drowsy in the beginning, as one of the speakers said. In case of CO2 narcosis, it's easy to snap on the NIV. Now the patient's getting out of that narcosis state and he's agitated. He's unable to tolerate his oronasal mask. So now comes the question, do we want to start sedation in this patient? A very, very difficult question, and a question that I suppose there's no right answer for these questions. But then we do have studies that have shown that for the right patient, and especially at the right dosage, it can help. So what is this right patient, right dosage? So first of all, as a personal recommendation, although there have not been solid guidelines, I would say our newer sedatives like dexmedetomidine, if we do not have underlying cardiac diseases or any other contraindication, bradycardias, hemodynamic instabilities, we can go for dexmedetomidine sedation. It's a light sedation. It mimics normal sleep, and that can actually help the patient to tolerate NIVs better. So once again, the same recommendation, the non-pharmacological approaches are to calm the patient should always be tried before administering sedatives. However, often these fail in these agitated patients, and we might have to resort to IV sedations. So now, after that 24-hour period is over and there's been a lot of plugging and drying, so the pulmonologist has just walked in and said that, yes, the patient is now improving. I'd like to clear the airways. I'd like to do some toileting. And so what interface? So once more for the youngsters, so for such patients, you can often do it with an NIV mask interface itself, as well as you can probably switch the patient to some interface like HFNO and do it. So these are the two interfaces, the two masks that we use most popularly for doing bronchoscopies in these patients. And next, when is this patient ready to be weaned from the NIV? There are a lot of people who have come up that when a patient is ready to wean, so it's basically the same. The core remains the same, that the patient is breathing at rates less than 25 per minute. He's been around clinically stable. He's been able to improve his arterial pH. Please remember, it's always the pH, not the absolute carbon dioxide value. Once that happens, you can probably wean. Regarding how to wean, once again, lots of literature, people have compared abrupt discontinuation of NIV with, tapered discontinuation over 3 days. We've got guidelines regarding this, and most studies have shown that there's actually no difference. But then in my experience, I've hardly seen clinicians go for an abrupt discontinuation. Rather, it's a tapered discontinuation that is most commonly done. And this is the pre-discharge, around 5 days, 6 days down the line from the ward when the patient is being discharged. This is the ABG. So you can see that the PCO2 is still 55. So the patient relatives, the family comes and asks us, so should we continue this BiPAP at home, because she already has that on rent? So what do we say? So once again, we are clear on this, that following an acute exacerbation, we should probably follow up the patient after 2 or 3 weeks before sentencing the patient to take something as uncomfortable as a BiPAP at home. And this decision should probably not be made at the discharge after an acute exacerbation. I do understand that there are frail patients where we kind of are uncomfortable to discharge home without support, but then this is what the data tells us. So a few key questions that we have answered from this case: when to put on the NIV, which patients deserve it the most, what settings, how to monitor this patient, whether or not we can use sedation, and how to wean and finally discharge these patients. That's all from my end. Thank you.
Thank you, Amrita. That was really good and comprehensive. Just a quick couple of things regarding weaning. One of the key criteria should be and is correction of acidemia, not just improvement, but correction of acidemia, particularly, in all cases. And as you say, there are studies going on. In fact, we are currently doing a multi-center study called NIVO, where we are comparing weaning of an IV after correction. So again, the correction of acidemia has to happen before one can even think of weaning. And then the other things that you mentioned, that they need to have stable respiratory rate, heart rate, not agitated, and so on. So all those things are important. Delirium control is very, very important, because as you know, that is associated with poor prognosis. Just coming to the other point about providing domiciliary or home NIV, two things. First is, as you quite rightly mentioned, in a proportion of patients, the hypercapnia will settle down by 2 to 4 weeks. So the hot HMV study had very nicely shown that if you do it around 3 to 4 weeks time, a good proportion of these patients actually have normocapnia. If they have persistent hypercapnia, and ideally they would have had to have more than 2 admissions. So 2 or more admissions and persistent hypercapnia is an indication. Another indication for domiciliary NIV is somebody who is coming in repeatedly, 3, 4, 5 admissions, you get them better, they go home, they again come back with severe hypercapnia. In that case, multiple recurrent admissions with hypercapnia, you would then initiate, not wait for another admission. And further group where NIV, domiciliary NIV has shown to improve mortality is patients with COPD who are on long-term oxygen at home, who are on 16 hours of oxygen. If they become hypercapnic, treating them with domiciliary NIV improves survival. That's the only patient group where NIV improves survival in domiciliary NIV settings. Just wanted to add those 2 points. Sure. I'll briefly show a couple of slides if that's okay. Now I need to let me do this. Hopefully I can.
Dr. Amrita, you'll have to unshare first.
Yeah.
So, Dr. Milind, how often do you use sedation in your setup in UK?
Not often. I would not say never, but not often. So if I try and share my screen, window, hopefully, and again, I think spending a little bit of time with patient, if you can, trying a little bit of haloperidol to start with, using alternative masks. So if they are claustrophobic, using a total face mask, getting a family member closer to patient, the non-medical part, if you can use these strategies before going on to sedation, then that would be better. Can you see my screen?
Yes.
Full screen?
Yeah.
Thank you. Just wanted to highlight here just a couple of slides really. So if we look at the left here, where that arrow is, so we can see that although the machine has tried to breathe, there is not a lot of air going on, particularly the red, line here. Can you see where my arrow is?
Sure.
There is hardly any air going in. And on the right, you can see much better flow volume loops. And the reason for that is this is a patient with obesity and COPD, and they had collapsed airway. What we did was get a nasopharyngeal airway in. So from an ineffective breath, we then moved on. So you can see tidal volume on the left hand side is 375, tidal volume on the right side is 550. So you can see, and that was because we got nasopharyngeal airway in, and that improved tidal volume. And another patient, so here, so you can see there is complete asynchrony. You just don't know what's happening. And although tidal volume is reported as 280, I'm not sure how accurate that is. Your inspiratory over expiratory time is 66% in patient with COPD. So that's too high. So that's leading to gas trapping. So changing controlled mode to ST mode, you can see much improved ventilation. Your TI to T-tot is only 28%, so patient is getting full time to breathe out, and your tidal volume has gone up and minute ventilation has gone up. So just using some of your flow volume loops again to look at and optimize ventilation. So have I stopped sharing?
Yeah.
Yeah, perfect. So I'll ask Dr. Supraja here whether she wants to talk briefly about obesity, hyperventilation. How much time do we have?
Exactly 8 minutes for 8:30.
Okay.
I think we'll be plus 5 minutes for the delayed start.
Okay.
I would like to share my screen here.
So do you want to briefly first maybe do a slide or two about obesity, hypoventilation, or you're quite happy directly to go on to the case?
We'll directly discuss because there's been an excellent. Is my screen visible, by the way?
Yeah.
So extensive discussion has been happening on the NIV, how to initiate, follow up, and wean and come out. So I have a case which where sometimes we do get patients with diagnostic dilemmas, like they come in. So this is a elderly gentleman who is morbidly obese, who was admitted in another hospital for a type 2 respiratory failure, the first episode in his 76 years. He gets admitted. He is there treated as a type 2 respiratory failure, query OSA, query OHS, and then he's discharged on a home BiPAP. And within 15 days, he comes back with a history saying that he has a fever, maybe low-grade fever, 1.5 days, and then he's not compliant with his BiPAP, and then he's progressively becoming drowsy. So this is a history with which he's coming in. And these cases are quite similar and familiar of late, especially in the last 2-3 years. I've been seeing such cases which are coming in first time with a respiratory failure. On examination, this gentleman is morbidly obese. The blood gas shows a type 2 respiratory failure, and there's not much of a metabolic compensation. So he's initially started on an NIV. Blood gas starts to improve in the first couple of hours, but then in the next 24 hours, he starts to worsen progressively. His GCS drops, and hence we electively intubate and ventilate him. To give a brief thing into his counts, it's normal, markers are normal, echo is normal, renal and liver functions are all normal. So it's a straightforward respiratory failure, which with his comment, maybe the history of fever says possibly a viral exacerbation. So and after intubation, within the next 2-3 hours, there is a whiteout lung on the right side. The left-hand side picture shows a whiteout right lung. So we do a bronchial toileting, shows thick mucus plugs, copious secretions, and he is cleared out. And the X-ray on the right side, which is exactly 1 month later. So this is a current gentleman who is right now admitted in the hospital for me. His X-ray has cleared up. His respiratory parameters have all improved. His blood gases have all improved. And a brief introduction, into look into the investigation. We did BAL multiple times. The third time we sent for a lower respiratory panel because the cultures were coming in negative again and again. The lower respiratory panel showed positive for adeno and coronavirus. So possibly it was a viral episode with a secondary bacterial infection. So the tract cultures grew XDR. So he has cleared all these, and now he has come to a state where he is off all infections, hemodynamically stable, and doing well. The renal parameters had a mild derangement, but that also has improved. So the course, day 2 he gets intubated, day 8 gets tracheostomy. We not NIV on day 20. Currently he is on overnight pressure control ventilation, daytime pressure support ventilation. Trial of tracheal mask, he is not tolerating it much, like say 15 minutes to half an hour he tolerates. After that he is going back onto the pressure support. And he's now in the ward with a BiPAP with a tracheal support, because that's one of the high-end BiPAP devices. Now, the reason why I have presented this is sometimes we are not too sure. We have not established the diagnosis. Like in this gentleman, was this an OSA? Was this an OHS? Is this an overlap? Right now, is a critical care myopathy also adding on to why he is not, though the gases have improved, though the x-rays have all cleared, the tidal volume on the ventilator is looking good and on the BiPAP is looking good, but still he is not able to come off the BiPAP support. So what exactly are we dealing with here? Second, how long are we going to treat? So the gentleman has been in the hospital for last 4 weeks. He is getting a little agitated now, so that he wants to go home. So should we send him home on a BiPAP and then get him back for a weaning and then come on to a tracheal mask and then remove? And in the future, are we going to put him on a BiPAP or a CPAP, probably with an additional study? So these are questions which are usually lingering. I wouldn't say these are very rare cases. Nowadays, we do see such cases. So I just thought weaning off the ventilator onto an NIV, that was one topic which I felt also the role of NIV post-intubation also plays a role. So that's why I have brought in this case. I leave it open to the panel for discussion.
Thank you for a good case. Thank you. Dr. Mandal, would you like to share your thoughts and experience, please?
So I think wonderful 2 cases, and I think Dr. Suprajit does have a lot of challenges. So classically, your patient fits into the diagnosis of OHS. When you say morbidly obese, we assume BMI of more than 30 and had come with a hypercapnic respiratory failure. So we would probably have to take it as an OHS at the moment, and probably what we would have done was try and wean off the tracheostomy and to narrow it down and block it and then close it and then put the patient on an NIV. And we would probably use the volume assured pressure support ventilator backup of the BiPAP with the AVAPS mode. This is the mode that we would probably have tried more, or basically to control the hypercapnia. the fact that he fits into the diagnosis of OHS, I would probably not look at immediately evaluating him for a possible OSA. There would probably be an element of, I would probably keep the EPAP a little bit higher than 4 and 5, probably at about 5 or 6, depending on what the settings are, and probably look at the AHI once the patient goes on to a dedicated NIV, and look at probably upper airway obstruction from that point of view. So that's the way that, sir, we would manage in our center, sir.
Okay.
No, totally agree. Couple of things. Whether initially patient could have been weaned directly onto an IV rather than trying to do a tracheostomy. But before that, walking a step back, as Dr. Mandal says, this is a clear-cut case of obesity hypoventilation syndrome, and whatever his AHI is, he has demonstrated.
Sir, I think we lost you.
Yeah, so before he comes in, so the reason why we were not able to wean off was a continuous, it was a picture of ARDS with a significantly low PO2. We had to continue on ventilation. And to be honest, we have agreed a low PO2 target so that we can start weaning him. So he is still maintaining on a FiO2 of initially on 100. We started accepting a PO2 of 70 to start weaning him off. So that was the challenge which we had in ventilation per se. So that was one reason. So somebody is stuck on the ventilator. We had a day 8. I thought it is better to go with the early track, and then trying to wean him off. And I wanted to also highlight on Dr. Amrita's point on the NIV failure. So how long do we wait before we call it as NIV failure and then start intubating? Yeah, so Dr. Milind is back. Yeah.
Sorry, I somehow got disconnected, but he clearly has got OHS. There is no doubt about that. No question about that. He's obese, he has got type 2 failure. So the question is, has he got something else? Does he have COPD? Does he have any neuromuscular problems? And have you looked at how he behaves when you completely take him off ventilator? Does he have any asynchrony? Have you looked at his vocal cords in terms of, is there any vocal cord trauma or glottic? Is he able to vocalize? Have you tried to let his cough down? Yes. Because as Dr. Mandal says, one option is to gradually get him into a smaller tube, ideally without cuff, if he can tolerate that, and move on to nasal or oronasal, NIV. I would try him without respiratory support, ideally when he is sat upright. I would look for arm strength, leg strength as a surrogate marker, unless you can do either a sniff test or you can do nerve conduction study to look for critical illness neuromyopathy. So those are the things to look for. The other key thing is, I would not worry about giving him support pressure. When you ventilate him fully. Ventilate him to normal CO2 as low as you can get without excessive pressures, and go for small time off. So give him trial of spontaneous breathing and gradually extend that. This gentleman is going to go home with a ventilator, whatever you do. The only question is going to be, do you send him home with a trachea ventilation, or can you wean his trachea off and send him home with a mask ventilation, which would be much better for all parties concerned. So I would not worry about changing modes and stuff. Set him on a mode, for example, so whatever mode you prefer, that controls his hypercapnia fully, gives him full support. Don't try and wean the support. Try and extend the period of ventilation, would be my suggestion. And look at gradual decannulation, as in, slowly reducing the size of tracheostomy, letting cuff down, checking his vocal cords, checking for aspiration, and looking for either neuromuscular or COPD or other pathologies.
Yes. Yeah, fair enough. So agreed. So this case I had brought it more for a practical standpoint where people understand how we have to wean off a track and onto a NIV. So that is the reason why I have brought in this case. Yeah, there are a couple of minutes. There was one question on pulmonary rehab in respiratory failure. Would you like to start on that, sir?
Happy to again take that. I think pulmonary rehab is absolutely essential, irrespective of pathology. It's well proven in COPD, and we sadly get too fixated on inhalers, but not enough on pulmonary rehab. And sometimes, actually, there are data that with good support and if necessary with an IV, whichever way, the more you exercise, the better your outcomes will be. So I'm a signed up member for pulmonary rehab brigade. So more the better, really.
Yes, and on nutrition, because it's a catabolic state in the ICU, and everybody tries to cut down on the nutrition. I think we need to, especially for the youngsters, we have to say that feed them well, and then possibly a little bit of exercise in the ICU, and once you're in the ward, a little more aggressive physio will help, because they are in a catabolic state. They're going to keep losing out their energy. So yeah.
Thank you. One take-home message from each of you. Will start with Dr. Mandal. Take-home message or two for us and for the audience, please, Dr. Mandal.
So nothing much. I think all of you have covered wonderfully. All that I would probably leave one message is, just don't apply the device and leave it to the patient to recover on its own. Just stand next to the patient, keep the patient monitoring, and make the decision subsequently. That would be my one take-home message.
Thank you. From you, Dr. Amrita.
You are muted.
You are on mute.
I'd say that the most important take-home message is monitoring the patient, something akin to what Dr. Mandal said, because this is what kills the patient the most in case of an acute exacerbation of COPD. It's been well documented that if you have an NIV failure or you're going that way and you do not intubate, a delay is actually what kills your patient. So I think that is, and it's not always, I know there are lots of scores, HACR score, this score, that score, but at the end of the day, it's clinically seeing the patient, and there's also no pre-specified time that at 1 hour you see this, at 4 hours you see this. You need to anticipate, and this will only come with experience. So looping in senior consultants would be a good idea, I feel.
Dr. Supraja?
Yeah, so with attrition of nurses and turnover of nurses and staffs and duty doctors, I think a standard protocol like how we pace the ACLS protocol, BLS all over, I think for respiratory failure, it has to be there in the ER and in the ICU so that nobody misses it. And I think rounds, you keep grilling them again and again on the same protocol. Yeah.
Thank you. From me, I would say, early initiation of NIV in appropriate cases, choose your mask. And again, as Dr. Mandal said, don't run away just saying start NIV. You have to be there. It's a treatment you have to monitor and adjust. It's not something like antibiotic you prescribe and walk away from. So I think on that note, I would like to thank all the panelists and speakers. I hope audience have found it useful. I would like to again thank the Indian Chess Society, CSM, and Dr. Shivani for organizing this webinar. Thank you for giving up your time on Sunday. Have a good evening.
Thank you. Thank you so much.
Bye-bye.
Thank you so much to all our panelists for being here with us today, giving us time. Thank you so much, Dr. Milind, for holding the program together. I would like to thank Dr. Shivani Swami because she has formulated the whole program and she's been there from the beginning, supporting us and formulating this entire program. Thank you so much, ma'am. I would like to thank the Southeast Asian Academy of Sleep Medicine and ResMed for doing this webinar with us. Once again, I would like to thank Dr. Himanshu Garg, Dr. Supraja, Dr. Amit Mandal, and Dr. Amrita Bhattacharya. Thank you so much for taking out time and being here with us today. As for our viewers, thank you for joining us. We hope you keep supporting us and giving us so much love. And we are going to soon bring back another webinar for you with eminent faculties again. And until then, stay with us. And if you have any queries, you can email us at icsofficeexecutive@gmail.com. And before we close, I would like to remind you again that NAPCON 2023 Delhi registrations are live. Please join in. Please be there. And we are going to see you at Delhi. So thank you so much. This is it. Thank you to our faculties once again. And we hope to see you all soon in other ICS endeavors. Thank you.